All right, welcome back. We're in the home stretch here. So our next session is going to be What Does the Evidence Show? Long-term lessons from Teen Labs and Amos. Most of our speakers need no introduction, but we have Justin Ryder, our Vice Chair of Research in the Department of Surgery here at Anna Robert H. Lurie Children's Hospital. We have another man who needs no introduction, Dr. Thomas Inge, the Chair and Surgeon-in-Chief of this hospital, as well as this event. And then Dr. Mikowski, a professor of clinical surgery and pediatrics at Nationwide Children's. And for our moderators, we'll have Dr. Michael Humrath from Cincinnati Children's, as well as Dr. Berzoni from Texas Children's Hospital, Austin. Thanks.
Thanks, John. All right, I got 3 slides and 3 lessons. And I thought I was going third, so it says part 3, but I'm going first. All right, so lesson number 1. Can we predict who's going to respond long term? So this is our 10-year data from Teen Labs, and we use latent class analysis to identify 4 different weight loss phenotypes. We've got what I like to call the super responders in black below, 18% of our cohort that at 10 years, mean weight loss was 43.7%. Pretty remarkable. We have in yellow a third of our cohort that at 10 years had a BMI reduction of around 27%, which I'll consider to be a great response. This is the ideal of what we want. You can see at 1 year, they achieve about the same weight loss as the black group, but at 2 years, they don't keep losing, and they have this slow trajectory towards weight regain. In blue, we have a non-ideal response, but still a great response. At 10 years, the BMI reduction was 12.6%. Why do I say it's still a great response? Well, at 10 years, it's still just as good as 1 year with semaglutide. And actually, at 1 year, the weight loss is 25%. So still quite a good response. But we do have this red group that doesn't lose as much weight initially and regains and is back to their original BMI on average at year 4 and has a slow trajectory towards weight regain. So the answer is, or the question I have for all of you is, what's the best predictor of long-term weight loss response here? The answer's in our paper if you read it, but yeah, it was. So we did a whole bunch of permutations. It's not sex, it's not the procedure, it's not site, as much as Mark and Tom and Mike all would like to say they're better surgeons than each other. It was equivalent across sites. It was 6-month weight loss. So the more you lost at 6 months, the early weight loss response was the best predictor of long-term weight loss response. And the nadir for that was around 24%. If you achieve a 24% BMI reduction at 6 months, you were likely to be in this black or gold group. Otherwise, if you didn't lose 24%, you were likely to be in the red or blue group. So perhaps if we evaluate people between that 3 and 6 month window, and if they're not meeting this 24% benchmark, that's when you'd start loading them up with every med that you can possibly think of. All right. So that was my first lesson. My second lesson is, can we predict who's going to respond? I think that's actually kind of the holy grail. Patient walks into your office, you look at them, you have no idea if they're going to respond or not. Can we use a biomarker to identify who's going to respond to surgery or who's not? Who's going to be black and gold, or who's going to be red and blue? And can we do that before we actually do the surgery? So one of the beauties of Teen Labs is that we have the ability to do some back translation work, and we've started to do this work. We're continuing to refine it. We've done genetics that cannot predict this. Okay, so that abstract's been presented. We're working on the paper, so genetics is not the answer. We've been doing some proteomics. We're not quite ready there yet, but with our metabolomics data, we've identified a number of baseline metabolites. So this is metabolites prior to surgery that are associated with long-term weight loss maintenance, belonging to one of those two groups over there. And if we put this into a model to try to understand whether or not they're predictive of long-term weight loss maintenance, or those response phenotypes that I just showed you, if we look at demographic characteristics alone, our model is an AUC of 0.56, or slightly better than a coin flip, on the ability to predict who's going to have a good response, a favorable response, or a poor response. But if we look at just our metabolites alone and put those into the model, the AUC is 0.85. Pretty darn good, an 85% ability to predict who's going to belong in those two groups. And actually, if we add on top of that our demographic factors, it's the red group that says combined, our model actually gets worse. So demographics make our biological model worse. Continuing to work on this and refine it, but I do think we're going to get to a state where we are able to do some, fancy blood tests and be able to identify what might be the appropriate first treatment option, towards precision medicine of patients. Whether it's telling us they are going to be a great responder to bariatric surgery, let's just tell them skip meds. The model says you have a 90% chance of great success with bariatric surgery. Or it says, hey, we're iffy on you. Why don't we try a less intensive treatment approach to start with? Or we might need to combine these treatments approaches. So I think we're going to be able to get to a place where we have some good predictive biomarkers that help us with clinical decision making. And then the last lesson I have for you, before Tom and Mark come up here and tell you about their lessons, was my same lesson from earlier, that I think we should stop doing placebo groups. So on the left side, we have Torsten's AMOS 2 study. So AMOS 2, I missed half of his talk, but if he didn't cover it, is a randomized controlled trial, 13 to 16-year-olds, of bariatric surgery versus intensive lifestyle modification therapy. You can see in blue here the intensive lifestyle group, and you can see in the red group here sleeve gastrectomy. This is expected. This is what we would expect of the outcome. And you say, well, it's not truly a placebo group. Yeah, but the lifestyle isn't going to treat the underlying biology, the root problem. And actually, at 5 years after the randomization, so there's 25 kids in each group, 19 out of 25 kids that were randomized to the blue group or the lifestyle group had bariatric surgery in this cohort. So again, I think it's unethical to randomize when we actually have real treatments available. And so this is, again, the semaglutide versus placebo data. And again, the placebo group, no weight loss at 1.5 years. Imagine being randomized to a treatment that does nothing for you for 1.5 years, and then they actually didn't have an open label extension, so these kids did not get access to the medication afterwards. I have real ethical challenges with that. And actually, if you talk to Torsten, he's got a really interesting story that I don't have time to go into here about the ethics of this. They had a really hard time convincing an IRB to let them do this. Eventually, they got around it because they waitlisted, controlled everybody. So at 2 years, they offered surgery to everybody. And again, by 5 years, 19 out of 25 had already had bariatric surgery. So what's my solution to this is let's compare real treatments versus real treatments. Meds versus surgery. Most of you know that I really want to do that. Meds versus med, different surgical treatment options with meds on top of them. I think that's the only way that we're going to advance the field forward if we stop doing these treatments that aren't real treatments. And that is my last lesson, and I'm going to pass it off to Tom.
Okay, at the risk of becoming repetitive and unwanted as a old face here, I wanted to come and tell you a few of the insights that we've had with Teen Labs, and 3 in particular, big picture teachings. The first, actually, from my standpoint, I was honored to lead the study group for 18 years, and just current status, Justin and I, as well as the entirety of the public, have available the entire database. So it's available at the NIDDK website. You do have to go through a process to get access to the data. But we're continuing to mine it. The messages, though, the three coherent messages, the first is when people ask for collaboration, say yes, because you never know where it's going to lead. I'll tell you a little bit about that story in a minute. And the second one is don't blame the patient. You've heard that? Now I'll tell you exactly why to don't blame the patient. And then the third is don't pollute your bodies. You're going to see all these tied together in just a minute. So Teen Labs, again, most of you know this. It had been a prospective, multi-center, non-randomized, single phase, 3 different study groups, that is, but really no absolute control group study at these 5 major sites. The PIs, many of whom are in the room right now. We studied these patients at 6 months, 1 year, and actually annually until year 15 for some early adopters, but 10 for essentially everybody. And the collaboration part goes back to an Obesity Society meeting that I went to probably a decade ago, where the senior scientist from USC approached me and said, "Do you got any specimens? We're thinking, you know, that in this band study that we've got going on again a decade ago, that kids that live closer to freeways do more poorly with weight loss after band surgery than kids that don't live near freeways." And I was like, okay, that sounds kind of odd. I'm not a toxicology guy, but sounds like an interesting class. Yes, we've got specimens, we got data. And so introduced this to Rob McConnell, was his name, the senior scientist. And what they did with these specimens and our data was remarkable. It taught me that, you know, in addition to the lay press talking about these forever chemicals, they actually exist and they're harmful. So these are per and polyfluoroalkyl substances, PFAS molecules that have a lot of indications, a lot of uses, industrial applications, but are in a lot of consumer products too that we have in our home. They are detected in the blood of almost everyone in the United States, including us in this room, and they're quite resistant to degradation. And oh, by the way, they're linked to metabolic dysfunction. So they really don't go away, and we don't have a way to destroy them. And the hypothesis is that because they are they're implicated in excess weight gain, that they might actually also be implicated as an endocrine disruptor for diabetes as well as for potentially weight loss. So here's just an awful visual of all the places that the EPA has measured these forever chemicals and found that there are varying levels in our water source. So they're also not just a handful of chemicals that we're talking about. Almost 9,000 known PFAS contamination sites in the U.S. with 143 million people that have PFAS in their drinking water. So the fascinating fact that you'll leave with today is that until a couple years ago, 2025 I think was the first paper that came out of this collaboration, there was zero data on the impact of PFAS chemicals on bariatric outcomes. None in the adult literature, none in the pediatric literature. But this one lady, a postdoc at USC, who's now a faculty member, I think at Emory, is Brittany Baumert, and she worked with Lita Schatze, and Rob McConnell is here, the guy that just came up and said, "Hey, I'm Rob McConnell, do you have any specimens?" Back a decade ago. And they found, when they looked at those specimens, the Teen Lab specimens, that, and this is obviously not a scientific talk per se, but it was real science behind it. You see that over the first 5 years, for all of these cogeners of these PFASs, they have a little bit upward jog at 6 months. My interpretation, our liver and body fat stores are liberating the PFAS molecules, and then they're actually being excreted from our bodies. And then they drop off over the 5 years in these specimens that we gave them. But what they did that was really spectacular is they started looking at all sorts of outcomes we care about. Oh, by the way, weight loss, okay? They looked at diabetes, they looked at hypertension, they've looked at other things as well and are continuing to look. And the bottom line is the kids that had low exposure to these environmental toxins, low exposure at baseline, had the best maintenance of their weight loss. So years since surgery, % weight loss, couldn't get any simpler than that. I'm just a bariatric surgeon, of course, so you got to keep it simple. But the greater weight regain was associated linearly with the greater exposure vis-a-vis the measured PFAS concentrations in their serum at baseline. So there are specific agents, the sulfonic acids in particular were the nastiest ones. So the question I have for the environmental toxicologists in the room, or for Brittany actually, and that I ask my own team, what the hell do we do about it, okay? So we've measured this, we've published it in peer-reviewed journals. Now what can we do in the clinic about it? Can we measure PFAS preoperatively? Well, in fact, Quest has a send-off. You can get your PFAS levels, I said there are thousands of these, but you can get 8 measured for about $500 by Quest. So we did that in a group of patients. My team humored me to say, yeah, we'll send the send-outs and see what they do. It turns out, when we looked at a few of these and then talked to Brittany about it, that most of the analytic work that they did in the lab grade, research grade data, was actually looking with mass spec at much lower concentrations. So they were impactful, lower concentration, but they were below the limits of detection for the commercial Quest-based tests. So we can't measure them easily unless we got a big lab that can do that. And so we can maybe give an antidote. I did a little literature review, and there are certain substances like Questran that will actually help to detoxify yourself if you've polluted your body with PFAS, and we all have, and you care about getting rid of PFAS. But the thing about that is, I talked to a cardiologist, because Questran, of course, is the old drug for hyperlipidemia, and it doesn't taste that good, and so teenagers tend to like tasty things. And so we didn't think that would be a great intervention as well. And then, oh, by the way, well, what happens? You get rid of it for a period of time, and then you're back into the same polluted environment, right? Look at the water supply. Elizabeth is shaking her head yes, because she's taught me all this. So what do? You call the EPA? I mean, I don't know. What are the 10 scariest words we've ever heard? It's like, I'm from the government and I'm here to help? No, I don't think so. I don't think so. So what does it come down to? It comes down to Mrs. Inge. So Mrs. Inge installed the black Berkey water filter in our home about 20 years ago, and I just fill it every morning, and I just, that's just what we do. So we have filtered drinking water. And in fact, when you talk to Lita Schatze, when you talk to Rob, when you talk to Brittany, the biggest intervention that the environmental toxicologists can actually do for this problem is, in fact, tell you, filter your water, drinking water, cooking water. You're going to breathe these things in, you're going to touch things that have them on them, and from a practical standpoint, the best you can do is that. So, broad collaboration, save specimens, don't blame the patient. The reason I said don't blame the patient is because it really hits home that they didn't do this. The ones that regaining weight that are correlated with higher levels, they didn't even know. I wouldn't even know what my levels are right now. And then, of course, don't pollute or detoxify your bodies. We'll take questions at the end. Thank you.
Okay. And non-surgeons, anyone who's interested in obesity has a role in legislative advocacy. So for those of you that get emails from APSA, look out for the 2-minute turnover, which is coming very soon. Let's see. Oh, I see. Okay. So to wrap this up, and as the person that probably has the least data to talk about here, of course, I fixated on a title slide. And even though Todd Ponsky is not here, he would be proud to know that I used Cchmc. I tried to put our actual faces into this, and it didn't work so well. But this really speaks to Tom's comments about collaboration. And I will tell you on a personal note, having been part of Teen Labs for, effectively most of my career, when I first became a faculty member in Columbus, the first thing I did was drive to Cincinnati because that's where Tom was. And Tom bought me lunch, and the rest is history. And here I am today. So I thank you for that. It's been a great ride ever since. So you can see Captain Inge. Is there. I'm in the front, Lieutenant Commander Ryder, Lieutenant Commander Helmrath, and Anita Krokulis, who's not here today, but had to be represented as well as other people, including Mac Harmon, which we all dearly miss. So I was asked to talk a little bit about some of the limited data that we have on the offspring related to metabolic or following metabolic and bariatric surgery in the adolescent time period. And just, we've heard all of this before, so I'm going to jump through it pretty quickly. We've heard all these numbers before. 20% of the pediatric population is affected by obesity. This represents about, 4.5, 5 million adolescents who are class 2 obesity or higher. The World Obesity Federation has showed us some sobering information that says that these rates will double by 2035. There's obviously strong concordance between parental and childhood obesity. It's multifactorial. I'm not going to spend a whole lot of time talking about what drives all of that. That's a conference in and of itself. And what we do know from the very limited amount of data that's out there is that offspring from mothers that have had bariatric surgery may represent an increased risk for childhood obesity, and we'll dive a little bit into some of that. Data specifically looking at mothers or offspring of mothers that have had metabolic and bariatric surgery during adolescence is truly lacking. When I looked at this, this article by Dickens et al. Really just summarizes most of the literature that's out there, or I guess most of the impactful literature that's out there. This was a systematic review of about 12 articles that the authors included if they addressed offspring characteristics and or parenting and feeding practices. Most of these studies, the vast majority of these studies, were the offspring of mothers who had bariatric surgery during adulthood. So again, not the cohort that we've been focusing on. Most of the offspring were delivered before maternal metabolic and bariatric surgery, and they in aggregate from this study were shown about 45 to 50% to have high risk for obesity. Offspring that were delivered after metabolic and bariatric surgery, interestingly enough, there are some markers that there are some healthier childhood BMI rates, as well as time-limited improvements, including offspring lower weight gain, increased physical activities, improved eating habits, and so on and so forth. And I would encourage you to have a look at this article if you're interested in some of the details. In addition, some of the family relationships following metabolic and bariatric surgery in the linked female parent, include parental cognition of child's weight status, which may inform some of the feeding practices that have been looked at. So from a Teen Labs perspective, again, using the background of severe obesity, increasing the risk of pregnancy-related conditions such as gestational diabetes, hypertension, cesarean section, and some of the already set knowledge in the literature, again, quite limited at that, but that metabolic and bariatric surgery increases risk for preterm birth, slow for gestational age, delivery, preeclampsia, and nutritional deficiencies. We looked at the Teen Labs cohort with the specific aims of developing reports on maternal and neonatal outcomes after metabolic and bariatric surgery, again in our Teen Labs cohort, to evaluate rates of adverse pregnancy outcomes for mother and child, and to look at comparative outcomes against age-based U.S. normative data. This was done again, over the 10-year time period, this was presented last year at the Endocrine Society. Out of the 260 eligible participants for this particular analysis, which represented 135 pregnancies from 88 mothers, we had some interesting results. Again, some of this is not surprising. It's been touched on before with other Teen Labs data. The mean age was 17 years, which has been mentioned. Mean BMI was 51, and these were mostly white participants. When we look at just some of the initial observational data of the 105, or rather of the 135 pregnancies, there were 105 live births, 21 spontaneous abortions, 7 induced abortions, 1 ectopic pregnancy, and one stillbirth. Looking at maternal outcomes, mean pre-pregnancy BMI was 38, so still, concordant with some of the information that's already been reviewed here. Going into these pregnancies, most of these mothers still had class 2 obesity, which in and of itself represents a risk, as I've already alluded to. Gestational diabetes amongst the mothers analyzed here was about 12.4%, which is about three and a half times higher than the U.S. normative rate of about 4.5. Although, interestingly enough, preeclampsia rates were very similar to U.S. normative data, around 10% or so. Cesarean section was significantly higher, approaching 50% compared to U.S. normative data. Pregnancy and perinatal outcomes themselves, there was about a 17% rate of preterm birth, which is about twice the rate of normal national data, mostly occurring later in pregnancy, about 35 to 36 weeks. Mean weight of the offspring was about 3 kilos, which is lower than normal, and over 50% of mothers exceeded recommended gestational weight gain during the pregnancy period. Postpartum, most mothers, over 65%, initiated breastfeeding, but the vast majority of them discontinued breastfeeding within 3 months, obviously representing an opportunity for increased or improved counseling and nutritional support. So in conclusion here, we saw that the current analysis really provides the first detailed examination of pregnancy-related outcomes amongst women undergoing bariatric surgery during the teenage time period. Post-adolescent bariatric surgery offspring have higher risk for gestational diabetes, cesarean delivery, preterm birth compared to age-matched norms, while preeclampsia, as I mentioned, was comparable to normative national data. Lower birth weight may reflect fetal growth retardation during these pregnancies. However, implications related to long-term metabolic health are unclear. And then finally, longer-term studies obviously are needed to inform potential perinatal guidelines in the setting of prior metabolic and bariatric surgery. More recently, in an attempt to look at what's happening a little further down the road, we're in the process now of doing an analysis as a pilot study in a single-center fashion. This was conducted at the Columbus site, looking at a number of different variables after childbirth, including characteristics of maternal feeding practices, health behavior, and family function, describing maternal, metabolic, and bariatric surgery weight trajectory based on offspring status, and exploring perceptions of undergoing metabolic and bariatric surgery during parenting, or including parenting behaviors. This was a mixed model type of analysis. In terms of the total eligible cohort for this, we identified 6 mothers from the Columbus cohort, 12 of which were agreed to be part of this pilot study, which you can see here included a combination of collection of demographic data that was done, as well as completing some surveys. Survey at 15 years now included self-reported height and weight, validated behavioral family parenting tools, and included, you can see here, child activity for consumption of fruits and vegetables, the child feeding questionnaire, family assessment device, general function scale, and family meal importance. These are all validated scores. The results show that in general, mothers are actually doing quite well. Most of their offspring related to this, or their first offspring related to this, are consuming fruits and vegetables, are physically active, and there is related concerns about screen time. When we look at some of the subscales, there were some results, including a behavior around parental behavior around restriction of food, monitoring of food consumption, and maternal responsibility around food that actually scored a bit higher than correlative data amongst mothers that had bariatric surgery as adults rather than as pediatric population. And then finally, just to share a couple of the comments that were made during some of the interview process, I wanted to just share some of the comments. This is one comment: I probably could have worked on losing weight more, and that wouldn't have been an issue. As a teen, it's hard to, it's different and hard. I was in a weird place at age 18, still trying to figure things out. I see you. And just to wish that I had given more time to myself. And then finally, I mean, after surgery, I was successful, but I wound up getting pregnant. So I got a blessing out of it all in the end. So I think the answer here, or the lesson here, is we really do need to keep following these patients, particularly mothers and offsprings, and some of the attitudes. I think that the parenting behavior following bariatric surgery is relatively good. The patients are receiving parenting behavior modelings that I think are encouraging, although I think the mothers themselves are struggling with a number of the variables that we've measured over time, and I think that there'll be more to follow after this. Thank you.
We can open up for questions. I had a question for the three of you, but based on Justin's talk. One of the things we haven't mentioned today yet is the size of the sleeve. And I know there's a reason why we haven't heard of it, but I know there are surgeons who do not believe in the size of the sleeve. They believe in purely metabolic change. I think there are surgeons that really believe in the physical and the mechanics of it. And I know the first 6 months is a big milestone, but why do you think that happens? Because there are studies that show that at 6 months, if the volume of the stomach was a certain size, you lose much more weight. So I think it was 100 milliliters, what they measure in the volumetric studies of the stomach. So is it worth revisiting that and studying that as we keep moving forward for weight regain? Because it can't be just magic at 6 months. Something is happening different, from one patient to another. And I think revisiting that and studying the volume of the stomach at specific times prospectively, or just look at our patients, will be important, right? There's people who cut 6 centimeters from the pylorus, people who cut 2 or 3 centimeters from the pylorus, people that make it very tight, people that make it very loose. I don't think it has to do with the size of the bougie, because you could make it tight no matter what kind of bougie you have in there, I feel. So I wonder how you guys feel about that.
Yeah, I don't believe it probably plays a role. I know that the adults have really focused on this and perseverated on it and studied it with volumetric studies, with CT even. I know animal studies have been done that really show this is much more of a biological phenomenon rather than a size. But others...
Yeah, I mean, I think over the time that we've been doing sleeves, which I think we started in like 2012 or so. So we've had a long enough time. When we first started, we were using 32 French bougies, and we were getting quite close. I think a lot of patients were vomiting because of that, which I think led us to back off and increase our bougie size. At the end of the day, I don't think I've seen any specific difference in weight loss. I'm not sure that it really makes a difference whether you're using 36 or 38 or 40. I haven't seen at least from an anecdotal standpoint, I haven't really analyzed our own cohort, but I haven't really seen much difference.
And that said, when there's magnificent weight gain at 2 years or something, then we do get an upper GI if we see that the stomach, it has regrown, and I've seen it regrow once or twice, then we do a resection, a re-resection. So.
Yeah, I wonder where it's big to begin with also. I don't know how much it grows. When did it start to grow? Is it after the 6 months, or did it start a little bit bigger than normal? I don't know. Just bringing that up as a question.
Jamie.
Hi. Thank you all for your talks. You gave us a lot of potential topics to chew on. I was reflecting that for some of the questions that we're hoping to move to answer, including precision therapies, and even some of the economic analyses that we started earlier this morning for demonstrating cost savings, Could anyone speak to platforms that currently exist or in the future to facilitate multi-site data collection across our programs nationally?
Cosmos.
Just to plug John here for a second, he did have a paper accepted last week in JAMA Open of the 10-year cost effectiveness of adolescent bariatric surgery. So it should be in press in a week or so. Take-home message is sleeve gastrectomy is more cost effective than Roux-en-Y gastric bypass by a long shot. So we've been using Epic Cosmos a lot lately. We've got 4 or 5 abstracts about to be ready. That's sort of how we're doing multi-institutional studies, because getting a data use agreement across 50 sites takes 2 years and impossible and takes a lot of coordination. Rather, instead of that, just take everybody who's opted in to Epic, which is 300 million lives in the United States, and just use that data. Now, it does have some granularity issues. It does have some issues with adjudication, but you can do some statistical techniques to take care of that. So that's how I've been thinking about multi-institutional collaborations, is not doing them and using instead the big data that we have.
Two more quick questions and quick answers.
Yeah. As an alternative to that, we're also looking at Epic Cosmos data, and I think it's awesome, but there is a smaller, kind of more nimble group of us that have executed data use agreements across 7 sites now, and anyone who is interested and has a research infrastructure to do that right now, we're unfunded and retrospective, but if you stay for APSA, some of our work will be presented at that meeting, and we're called Cchmc, the Children's Obesity Surgery Multi-Institutional Collaborative, and anyone's welcome to join us.
Quick question, but I speak slowly. I was intrigued by what you said, Tom, and I was wondering if there were any socioeconomic correlates with the people who live closer to the highway and the PFAS exposures.
Yeah, Justin, help me with this. Did she correct and adjust for SES status? She did, yeah. So, no doubt that that's true. Statistically, in this work, though, she focused on, what was the raw effect of the chemical itself. And so those are statistical adjustments that are made, but there's no doubt there's truth to what you're saying, that the most disadvantaged probably do have addresses that are, in places that have probably the worst. Okay. We're going to have to wrap this session, so we don't want to intrude too much on the next sessions. John, am I introducing you guys, or okay? Yeah, great. So we have an exciting panel coming up with Kanika Boanjalo from Prosper, Texas, Sean Stafford from Woodlands, Texas, and Cornelia Griggs, back again by popular demand from Harvard, MGH, 200 years of legacy, and no, I shouldn't say that. She can say that. Only she can say that, sorry. They're going to be weighing the evidence, game-changing studies in adolescent bariatric surgery. Stay tuned. Oh, sorry. Matthias and Jeffrey.
Great. So some of you in the room will recognize your work being presented. We've already heard some of this data today, so think of this talk more of a recap and sort of a description of the arc of the evidence and where we're going. We're going to review 10 papers that together capture where we're heading, and they tell a story about a field that's moving from proving efficacy to improving access, standardizing care, and building the long-term systems adolescents need after surgery. So why these papers? Why now? The central question is no longer simply, does adolescent metabolic and bariatric surgery work? Thanks to Justin and Tom and others. The stronger question is, if it works, why do so few eligible adolescents reach it? How do we integrate medications, and how do we build programs that can care for young people, not just through surgery, but through their transition to adulthood? 10 papers, 3 arcs. We've organized the talk this way. First, the evidence base. Second, how treatment delivery is changing in the GLP-1 era. And third, what pediatric, metabolic, and bariatric surgery programs need to build for long-term, inclusive, biologically informed care. So arc 1, the evidence is built, but the bottleneck is access. The premise here is simple but important. The evidence base for adolescent metabolic and bariatric surgery is now strong, as I've mentioned, and the bottleneck is no longer whether it works or horrified gasps that we're actually doing it. It's whether the patients who need it can actually reach it. We're starting with another paper of Tom's, a 2025 commentary that was in SWORD, which frames the problem we're here to discuss. Over the past 3 decades, obesity in children and adolescents has more than tripled. As of 2021, an estimated 174 million youth are affected worldwide, and in the US, severe obesity is now present in about 9% of adolescents. And despite that scale, fewer than 1%, far fewer actually, of eligible adolescents access surgical care. And the authors in this paper argue, and I think the central message is, that the evidence base is no longer the primary obstacle. The field has to move from proving efficacy to expanding responsible access. Passive availability is not access. The conceptual shift they offer is this: underutilization should not be interpreted as lack of need. Just because adolescent metabolic and bariatric surgery is technically available somewhere does not mean it is accessible. As we've heard from some in the room, our programs that we're running have long wait lists, are under-marketed or underappreciated by our various institutions. Essentially, referral pathways, family and provider education, insurance coverage, and program capacity have all lagged behind the data. So again, passive availability is not the same as real, especially equitable access. So what does this mean for us as pediatric surgeons and pediatricians and providers in the room? This paper makes the case that adolescents are being lost at every step of the pathway, at recognition, at referral, at insurance authorization, a huge problem in some states, at evaluation, and at follow-up. That's a big problem in our program. A lot of my kids stop showing up after even 1 year, or especially 2 years. And I've had that problem reflected back to me from other surgeons in the room. This is fundamentally a call to action in this paper. The challenge is not simply to operate on the patients who happen to arrive in our clinics. It is to help build the pathways that allow appropriate patients to arrive in the first place. And I would say holding symposiums like this conference, giving us more visibility at pediatric surgical conferences and the broader pediatric community, is the first step towards doing that advocacy, and is really important. We need to encourage the next generation of pediatric surgeons and embrace our adult partners in metabolic and bariatric surgery and show them that this is an important, worthy patient population. Unlike topics like pediatric surgical oncology, where we see patient families and parents sort of galvanize around a cause or build foundations in the name of their rare disease, this is just not a patient population that is feels as empowered, or in some cases as savvy at organizing those things. And a lot of that has to do with societal stigma and internalized weight bias even within our profession. Second paper, the 10-year outcomes paper. We've seen these beautiful graphs from Justin and others, but I do want to sort of recap it in our arc, in our description of these papers. Teen Labs is the durability anchor of adolescent metabolic and bariatric surgery research. It's a multi-center prospective cohort that has followed adolescents through surgery and across the transition into young adulthood, allowing us to actually answer the long-term question, does this last? And that's something that everybody, whether it's a parent or patient in my clinic or another pediatric surgeon or any provider that I meet in the hospital. I won't belabor these graphs again because we've heard directly from the authors themselves, but at 10 years, participants sustained an average of 20% reduction in BMI, which is remarkable, and gastric bypass and sleeve gastrectomy produced broadly similar long-term outcomes. This is not a short-term weight loss story. This is a durable disease modification carrying through adolescence and into young adulthood. The metabolic outcomes are arguably the most compelling part of the paper. At 10 years, participants showed a 55% reduction in type 2 diabetes, a 57% reduction in hypertension, and a 54% reduction in dyslipidemia. When you remember that these are conditions that, when they start in adolescence, carry decades of downstream cardiovascular, renal, and metabolic risk, the magnitude of that benefit becomes hard to ignore. And I think this is the really compelling argument for operating on younger patients, is that we're buying them a huge, huge amount of lifespan, especially compared to some of the things that we do in surgery at the end of life in adulthood. Is adolescence too early for surgery? This paper also helps us reframe that question. Teen Lab suggests that the more honest framing may be the opposite, that for the right patient, waiting is a riskier decision. If a teenager already has severe obesity, type 2 diabetes, hypertension, sleep apnea, or fatty liver disease, every year of delay is another year of metabolic injury. And functional mobility and quality of life is improved as well, which matters enormously to the patients in front of us. I say all the time, I've never had a 16-year-old sit down with me for a preoperative visit and say, I want to lose 86 pounds. They say, I want to be able to do the things that my friends can do. I've even had girls look at me dead in the eye and say, I want to wear a crop top. I generally try and help them reframe around health goals, but I think it's really important to keep in mind the adolescent patient population that we're treating. Teen Labs gives us powerful durability evidence, but it also reminds us that the operation is only one piece of a long-term multidisciplinary treatment program, and we heard beautifully from a lot of you. Most of you ended up on this half of the room. I'm not sure how, but it was really special. Our third paper from Clinical Obesity takes the next logical step. Teen Labs shows surgery is durable, but how does it actually compare head-to-head with lifestyle intervention? We'll hear a bit more about meds next. This is a systematic review and meta-analysis of 5 clinical trials, 3 randomized and 2 non-randomized, including 367 participants aged 10 to 19, with 1 to 2 years of follow-up. So a focused, direct comparison, because this is what I hear a lot when I give talks either to a lay population or to pediatricians. It's like, well, isn't this just a behavior lifestyle problem? The weight loss signal is striking in this comparison. Compared with lifestyle interventions, surgery was associated with roughly 26 kilos more weight loss and about 25 percentage points more total body weight loss and nearly 12 BMI units more BMI reduction. This is not a marginal improvement. That's the difference between modest management and a genuinely disease-modifying intervention. The metabolic story is more nuanced, and I think it's worth being precise about what the paper does and doesn't show. Surgery was significantly superior in hemoglobin A1C, fasting glucose, fasting insulin, triglycerides, ALT, and total cholesterol. Blood pressure did not significantly differ between the two groups, which likely reflects relatively normal baseline blood pressures in the included trials rather than a true absence of effect. I'd argue that nuance makes the summary stronger, not weaker, and it underscores the need for larger, more rigorous long-term randomized trials in this population. So what's the takeaway? Foundations of metabolic and bariatric surgery care. The message is not that lifestyle intervention is irrelevant, far from it. Nutrition, physical activity, mental health support, and family engagement remain foundational, both before and after surgery. The message is that for severe adolescent obesity, lifestyle intervention alone is not an equivalent substitute for MBS, and that should change how we counsel families and how we quickly refer appropriate patients. With that, we move from the evidence base into ARC 2, how treatment delivery is changing in the era of GLP-1 receptor agonists, and where systemic inequities are still shaping who actually gets care.
So all of this is very relevant because while we were here, I got a call from our coordinator who told me that patients that we already have in the pipeline for bariatric surgery following the regulations for their insurance for Texas Medicaid are now being switched to something else and they're no longer eligible. So now I have to go back and tell these patients that have been doing the correct thing that they're no longer eligible until they turn 15, which that gives them, about a relatively short amount of time to gain another 10 points in their BMI. So it's devastating for those of us who practice this medicine, but it's really devastating for the patient. So I'm glad that everybody's here today. So in 2023, AAP clinical practice guidelines marked a meaningful shift in pediatric obesity care, supporting a multimodal treatment framework in which pharmacotherapy and metabolic and bariatric surgery are both considered legitimate components of care for appropriately selected patients, rather than treatments to be reserved only after repeated lifestyle interventions. That shift in framing has coincided with a measurable expansion in the adolescent obesity pharmacotherapy landscape. This paper reviewed MBS utilization change during rapid GLP uptake in adolescents versus adults from 2021 to 2023. It compared trends across race and ethnic groups. The practical conclusion, the central finding in this paper is that adolescent and adult trends diverged. Adult MBS rates declined, but adolescent MBS utilization increased. That suggests we should be cautious about assuming that medication era will affect pediatric and adult surgical practice in the same way. I would also argue that the decline seen in adults was somewhat self-imposed by not embracing the use of medications. I can go into that later if there are questions about that theory. The practical conclusion emphasized in this paper is not that medications are the enemy of surgery. It is that pediatric MBS programs need sequencing pathways. A limitation of the study was it only reviewed the MBSA-QUIP database, thus only accredited program data. This paper addresses the utilization of preoperative anti-obesity medicines in bariatric surgery. Adolescents increasingly arrive having been exposed to GLP-1 receptor agonists or other anti-obesity medications. The authors asked whether preoperative exposure was associated with postoperative weight loss outcomes after sleeve gastrectomy. This was a single-center retrospective review of patients undergoing laparoscopic sleeve gastrectomy. 103 patients had no preoperative anti-obesity medications, 14 had preoperative GLP-1s, 18 patients were on topiramate, and the study follow-up period was 1, 3, 6, and 12 months. Preoperative anti-obesity medication use was not associated with greater preoperative weight loss. From consultation to surgery, the groups looked similar. At 12 months, controls had 25% change in BMI compared with 17% in the GLP-1 group and 18% in the topiramate group. A careful interpretation is that adolescents who reach surgery after anti-obesity exposure may be a clinically distinct group. The programmatic takeaway is that anti-obesity medicine exposure needs to be documented and studied systematically and utilized selectively in a multidisciplinary fashion. It is important to note that only pre-op use of an anti-obesity medication was reviewed, not post-op. Thus, there is part of the story that has not been told here. Many practices, including mine, have started to intervene early with suboptimal post-op weight loss on with continuing medication post-op if pre-op utilization, and if there is no pre-op post-op utilization. We need standardized documentation, stop and restart criteria, and shared outcomes across centers. Even if we get the medication pathway right, access remains the central systems problem due to insurance and cost. This pediatrics commentary responds to Shapiro et al.'s analysis of adolescents meeting criteria for MBS. It found that in Southern California, approximately 600,000 adolescents were analyzed. 56,000 adolescents met anthropometric qualification for bariatric surgery. Only 10 patients had a history of bariatric surgery from the 56,000 that were eligible. These numbers highlight an entire system failure. Barriers occur at every level. Patient and family awareness and stigma lead to this. Clinician bias and misinformation, as well as low referral rates. I can give an example this week where one of my patients was told by the PCP that we had to stop Vyvanse after surgery because of the metabolic changes. So there's so much misinformation, that's what I'm talking about, out there that we have to combat. Of course, I told them we wouldn't be doing that. System-wide with insurance, geography, and center capacity. Policy, this has to do with inconsistent coverage, which I gave another example about that today. And data, the poor tracking of referral to surgical pathways as well. Equity cannot improve if programs do not measure the pathway. Pediatric bariatric centers should evaluate whether disparities are appearing at referral, evaluation, insurance approval, surgery, or follow-up. Patients with intellectual and development disabilities are often excluded from MBS because of assumption about consent, adherence, or postoperative support. This study builds upon previous studies that have demonstrated outcomes in patients with intellectual and development disability in comparison with typical patients, which I have also observed in my own practice. This was a single center retrospective review. Patients equal to or less than 21 years undergoing MBS, the total cohort was 103, and 9 patients had intellectual and developmental disabilities. The IDD group had comparable weight loss outcomes. Moreover, at 12 months, follow-up of 4 typical patients, they had B1, B12, or iron deficiency, whereas 0 of the IDD patients had reported micronutrient deficiency. Patients with IDD may have more structured caregiver involvement, more consistent routines, or more active team support. I have found this to be the case in my practice. This is especially true when interacting with my patients on the autism spectrum. They are very concrete thinkers. Thus, once they make the change, they are able to continue with it. The culmination of these papers allow us to make a broader ethical and clinical point. Pediatric MBS programs should not use disability as an exclusion. They should identify support needs, adapt care, and include patients who can benefit.
All right, on to the final arc, durable systems and biological nuance. This first paper here kind of addresses something that's brought up a lot when I give talks out, grand rounds or whatever. I'm sure I'm not unique in this, but it's that question raised by pediatricians, families, even endocrinologists wondering what happens to bone health when adolescents undergo bariatric surgery. And as this was brought up earlier today, I think it's a definite concern. We know that during adolescence, we're seeing that's a crucial time for accrual of bone mass. About 25% of peak bone mass is accrued during this time period, so it's a natural thing to wonder how this is going to affect it. This study was a meta-analysis. It looked at patients that were undergoing sleeve, Roux-en-Y gastric bypass, intragastric balloon, or oh gosh, why am I blanking on the ring? Sleeve, not the sleeve, the band, thank you, the band. Oh. All right, anyhow, we saw the things that we usually see, which is that BMI reduction is significant. It's about 12.5%. No surprises there, but there were really significant measurable bone density changes, particularly after the sleeve and the bypass, which makes sense. When we're looking at the bypass, we see that we're bypassing the duodenum and the jejunum. This is the area where most of calcium is absorbed via active transport. We see alterations in PTH secretion as well as changes in calcitriol and fibroblast growth factor. And both the sleeve and the bypass have a decrease in gastric acid, which is going to decrease your digestion solubility and increase your levels of malabsorption. There's also some issues with the decrease in bone loading. I think an example of this we've all seen recently is when the astronauts went around the moon and back, and just in that 10 days they had a significant decrease. This has been demonstrated after bariatric surgery, but the papers that have looked at this have pretty much demonstrated that that lasts about a month before the compensation kicks in and it stops. So it's not as big a factor as one might expect. So, whoops. I think that when you're looking at this, the most important thing to take home is that this is not a reason not to do bariatric surgery. It just raises an issue that we have to address. It's really important for us to not become more restrictive in our approach to this, but more structured. We know that obesity negatively impacts bone accrual during adolescence as well as remodeling of bone mass. And although metabolic and bariatric surgery may affect this as well, it's more of a medium-term issue, whereas the effects of obesity persist long-term. So, there may still be a benefit, but the way we can deal with this is through a structured approach, look at the baseline status of the patient, figure out where they're at, put them on a supplementation protocol that's standardized, monitor this to make sure we're getting good adherence. If it's indicated and if you have access to it, we're doing DEXA scans on all our kids. It gives us a good baseline before and after to see how they're doing in monitoring their bone health and finding those patients that may benefit from, say, an endocrinology referral. But the most important part of this is we've got to take long-term ownership of what's going on and make sure that these patients are not lost to follow-up. And really, this idea that the operation is really just one part of the care actually brings us to transition to the next paper, which is retention and transition to adult healthcare and adolescent bariatric surgery. For surgeons, we like to operate, right? We'd love to just operate on this and make it better for the rest of their life. But there's a lot that goes into this patient population. The pre-op is important. The pre-op training and education is very, very important as much as the surgery, and post-op follow-up, as much as it's not as fun as surgery, is vital to this. And when we look at our patient population, they're undergoing changes. Everything about adolescence has changed. Who you are at 16 is not who you are at 21, is not who you are at 30. They're changing lifestyle. They're taking more responsibility for their own health and their own care. They're going off to college or to work. These are all changes that are much different than the adult population where you get surgery, you go home to the same wife, the same kids, the same job, cooking the same foods. It's a lot harder to make those changes durable. But the fact that they are changing means they really need some support. And as was brought up by Dr. Zeitzman earlier, this time period that we're dealing with these patients with the average age of 17 where we're operating on, their frontal cortex is still developing. It's not fully developed into 25 years old. So we're also subjecting them to these changes and asking them to make good decisions about their health and their future when their decision-making capability is still developing. So support during this is vital. So what does this transition require? It really requires a good, strong infrastructure. And what I really like about this paper is that it's really operational. It gives a lot of QI-based interventions that we can do and incorporate into our programs to help ensure that this transition is carried forward. It doesn't just say, hey, you got to follow your patients, it's a good thing, not following is a bad thing. Really, it gives examples of what programs can build, things like registries, transition policies, having established handoff protocols and defined roles. And really, at the center of it is what we've, had to do the whole time, which is patient education and ensuring that they get optimal support throughout the process and for the years following. One of the most important parts of developing the support and getting these patients to continue to engage after they've had their surgery is developing a good, strong relationship between them and the staff in your program. And I don't think I can overemphasize that. So really, as it says, transition failure is predictable and preventable. Transition should start long before transfer. We should have a transition program and policy in place from day one, and we should make that clear to our patients. They need to know, hey, we're not going to abandon you after you get surgery. This isn't a one-and-done thing. We're going to keep following you. We're going to support you. If you need us, we're there. The program needs to reassess throughout who's ready, who's not for transferring to adult care. You got to figure out ahead of time who you're going to give them to. You can set up those relationships or work with their primary care or whoever you're going to turn them over to. And then you really need to follow them until they receive that care. You know, the handoff's really not complete when the referral's placed. It actually is complete when the care is established and initiated. This final paper is a little more scientific. It's looking at gut microbiome shifts in adolescents after sleeve gastrectomy. And this is pretty fascinating. It's, you know, they looked at this and reminded us that when we're looking at the way sleeve gastrectomy works, it's not just a mechanical restriction. We've talked about that already. It really does change the physiology. We definitely see changes, increases in the GLP-1 we talked about, increases in peptide YY. But there are also impacts on things like the microbiome, metabolites, as we had heard earlier, immune signaling, gut hormones, and possibly mechanisms related to their response to weight that we really haven't elucidated yet. So this was pretty interesting. They did this longitudinal stool sampling with the patients that were pre and post bariatric surgery. Did a bunch of sequencing, metabolomics, human, and did stool transplants. I'm glad this wasn't my job, but into germ-free mice to see what the effects were overall. And it was pretty interesting what the findings came out. There really were some distinct microbiome shifts, but they were different than what we see in adults. A lot of increased alpha diversity, enrichment of oral-associated taxa, which makes sense because we're ingesting, we have these oral flora. They go into the stomach, they're destroyed by the acid there, but now we've done an operation which is going to facilitate the transit of these organisms into the later GI tract, and it makes sense that that would they would be more prevalent there. But they've also noted there was a lot of pro-inflammatory mediators there. Interesting because this actually increases the risk of Crohn's disease in this patient population. It's been said 1.5 to 2 times the risk. But for those of us who have patients with inflammatory bowel disease, we see that they actually get better after bariatric surgery. So I'd love to elucidate that a little better. But really, this is important because this really opens new questions about why adolescents respond differently when compared to adults, why some regain weight, and whether adjunctive therapies could eventually personalize care. So future indications, this paper really emphasizes that MBS challenges biologies in ways that we're still learning to understand. The next generation of pediatric MBS research may help us predict who responds, who needs more support, and how to personalize postoperative care to ensure success long term. All right, so if we step back, the field's clearly entered a new phase. We have durability data, we have comparative efficacy data, we also have a major access gap, a rapidly changing medication landscape, and a need for more mature postoperative systems. The next era of pediatric MBS will be judged not only by whether surgery works, but by whether programs can deliver equitably and responsibly. All right, so the goal of this talk is not just to summarize the literature. The goal is for us to leave with a practical roadmap, refer earlier, integrate medications thoughtfully, measure access, monitor safety, own the transition, include supported patients, and collaborate across centers. I appreciate your attention. Thank you.
The speakers want to come up. There are a lot of messages there.
Yes.
And I have to say
But we
that
only got the yellow card.
that I feel I feel hopeful that we're addressing this and that we're talking about it and that we're making it. What would each of you say a one-line message to not this room, but people beyond this room should hear?
I think we have to convince patients, referring providers, and the next generation of surgeons that this is a really exciting era to be a bariatrician, right? I will be flat out honest, I did not go to pediatric surgery with the intention of being a bariatrician, but combination of good luck and a lifelong passion for serving the underserved and working with vulnerable patient populations landed me in this field. It's partially your fault, Jeff. And I have found it to be so academically and professionally rewarding, but we need to make that visible to more people, and we need to get that message to more patients and referring pediatricians.
I think it's just really important to recognize that obesity is a chronic disease. I mean, it's like diabetes, high blood pressure. You treat it and you get better, and you stop treating it, it comes back. You know, you can decrease the risk. You know, if you have diabetes, you can eat better, cut down your sugar. Same with obesity. We can modify lifestyle to help with this, but it's not something that there's an instant cure for. It's really going to take long-term investment into taking care of these patients. And I think not only the general referring population and the people in general need to acknowledge this, but the insurance companies and the people, they wouldn't deny your diabetes care. So why are they denying our obesity care? That's something that needs to be brought up significantly.
I think they said it well, but I will say that I think that the landscape is changing, which is a good thing. I think the general population at large is learning more about obesity. They're being more open to having the conversations, and we need to empower our healthcare providers to be educated and to be able to have those conversations once they are broached.
And to that end, how many people are a part of their medical school curriculum committees? And how is obesity handled in those, in the curriculum?
Well, I'm taking over from Bob Kushner, right? So here at Northwestern, the students actually get a lot more lifestyle medicine and obesity curriculum than in most medical schools, but that's because he's been here and that was his passion, and he's getting ready to step away, so he's, trying to hand it over so that it doesn't just die with his retirement. But yeah, I think just like listening to this, what you're saying, the hard part is I don't know if anybody has tips, but I feel like there's so much like internal barriers to what it is we do. Like I don't get to use the prior auth team because what I'm doing is not as important. I don't get to use the development office to raise funds because what I'm doing is not as important. Like there's just so many barriers to get the people within my own institution to like respect and understand the value of what, our work, right? I mean, again, this is the #1 chronic disease of childhood, and still people don't really want to acknowledge that it's important work. And I don't know how, without getting like angry, I don't know how to get people to pay attention. So I don't know if anybody has any ideas.
So I will say that healthcare is a business. And so a lot of what I'm hearing is that people at a certain level are not interpreting that this is a good business decision. And so what we've done at our institution is started a task force, an obesity task force. And so then we get, 10 people in the room that believe in it and that are thought leaders and that have the ear of the executive team. But we also tie this back to surgery. So I think it's a symbiotic relationship, and that it should be, because if an institution knows that they can at least recap something, it makes it easier. And even for our pediatricians, they may want to have an interest in it, but their RVUs go down when they start treating obesity. Because what we do takes an hour. It takes 1 hour, they can see 3 real child visits. That math doesn't math for them. So we have to get over that hump, and we can only do that when we move the needle up to the C-suite, honestly.
Yeah, Thanks, guys. This was really just a great overview. Cornelia, I sent you an article that I'm going to reference now, and I'm happy to send it to anybody, about implementation science that was published back in 2022 or 23 in JAMA. And I had first heard about this. Somebody presented this at the American Surgical a few years ago. And shockingly, that article cites, and this is not about bariatric surgery, this is just about evidence-based medicine, implementation of an evidence-based clinical practice framework. Pick your disease. 17 years on average. So this is not just a problem about obesity, pediatrics, bariatric surgery. This is a much bigger problem. And I think it needs to be dealt with at a much higher altitude. I think what we do in our own institutions is important, and I think that needs to continue, but I also think that we need to advocate at the level of professional organizations, at a legislative level, because this problem isn't unique to what we are all in this room about, but it's not going to go away until somebody figures out how to address it so that that 17-year arc gets shortened over time. So, interesting.
I completely agree. Even when you look at implementation of basic treatment standards for myocardial infarction, it's pathetic, right? And this is a relatively new evidence base compared to cardiovascular disease. So I completely agree. And as a girl who grew up in DC, advocacy and policy, and especially at the legislative level, I think is going to be essential. Hospitals have to be held accountable the same way they are for CLABSI and CAUTI for treating obesity, and it has to affect their bottom line, just as Cchmc said, in a measurable and painful way to get people to pay attention. And I believe they will, but we also have to, I think, there's a responsibility for everyone in the room to do good marketing and be noisy at their institutional level, at the state level, at the policy level, eventually at the federal level, but also to galvanize our patients and their referring base to be noisy about it as well. Because we've also seen that at my institution, is when the patients are banging down the door and calling and say, hey, I can't wait 9 months to see a provider to treat my obesity. They eventually start to listen.
And I think along those lines, and I completely agree, but we have to look at our own programs and go back home and reflect on what we're doing. Because if you think it's hard for a people, they have a real deformity, they're going to have pain after the surgery, they could in fact get their heart stabbed during the surgery, we book them right away. So I think it's our responsibility to also change that. There's patients that are going to need more, but there are patients that come super motivated and they want to get it done within the month, and we tell them, no, we'll see you next year. If you any luck, you'll get it done. And I think that's on us too. We can't just keep perseverating on how complex it is to get these patients to treatment.
How many of y'all operate on kids that need to lose weight to do that? These are kids, at least in Texas, I can't operate on until they're 15. They're diagnosed with a problem at 8 or 10 that if we could intervene then, they wouldn't need to be on the transplant list. And where's the justice in that? And these are the things that need to be changed in my mind. So.
Thanks. I just wanted to make a comment. First of all, the field has come a long way between when Tom and I started talking about this in 2002. One thing has not been mentioned, though. That's why I wanted to stand up. And we've learned a lot. And the key thing that we've learned that I haven't heard mentioned is the fact that adolescents do not have the same way of gaining and losing weight that adults do. And we have seen that over and over again, and then to expect the new medicines and stuff to come out that are geared towards adults to have the same effect on kids is not going to be the case. And the fact that we have multi-approaches to this, it's going to get lost that the natural history in the background is going to be not completely understood. So without controls, and if you're going to predict responses without looking at how it's affecting our kids, we're just going to make the same mistakes. So we didn't have good control groups that didn't have our focus. We had a longitudinal group, which is remarkably helpful. I don't know that we have the next longitudinal group today, and if you're going to trust that the things out of EPIC are going to give it to you, I think you're going to be mistaken. I think we have to have a tighter group. We can have that. That's going to answer some questions, not going to answer them all. If we want this field to go forward, we have to be able to figure out how to capture these patients during this time that I don't know where to get that funded today. But it is going to be, I think, essential in 10 years to have that data for us to understand why kids are different than adults.
Thank you, gentlemen. All right. We are in the home stretch, and we are excited to have two of our trainees, Christine Brichta, as well as, who is, by the way, DABOM, D-A-B-O-M, get it?
I liked it.
And John Rohde, who's DABOM in his own way, to come up, and they have two work in progress, what do we call them, or completed, nearing completion works that will be 5 to 7 minutes, two each, and we'll save questions to the end because we are a little bit running tight on time. And then at 5 o'clock, we're going to retire to the atrium and have a little reception. So thank you. Again, I forgot our moderators, Colton Wayne and Lyndall Dewberry, coming to us all the way from Kentucky. Yes, Lexington.
And
Thanks,
Ohio.
Okay. All right, so the first talk I'm going to give, and I apologize, maybe this works in advantage, is that I actually talk pretty fast. So the first talk I'm going to give is about the impact of bariatric surgery on MASLD and MASH. So I'm actually the liver transplant fellow here in my last year of training, and I completed a paper with Justin and the rest of the team related to this. So just as a background, for those of you who aren't as familiar, but MASLs are the new term for metabolic dysfunction-associated steatotic liver disease. It is the most common cause of chronic liver disease in children aged 2 to 19, with about 10% of children affected in the US. Adolescents with severe obesity are more likely to develop advanced liver damage, which progresses with inflammation, called MASH. And this is an indication that both the AAP and ASMBS support as reasons for considering bariatric surgery. So the objectives of this talk, I'm actually just going to review what pediatric MASLD definition actually is and how it actually differs compared to adults, the prevalence of MASH in the MBS population, and then review the outcomes of MBS on MASLD and MASH in pediatric patients. So to review, a healthy liver actually has less than 5% fat in the hepatocytes. The development of MASLD is actually defined as when you have more than 5% fat in the liver, confirmed either by a liver biopsy or on imaging that quantifies that, coupled along with the presence of at least one cardiometabolic risk factor. MASH is a definition that's used when there's actually evidence of inflammation, ballooning, or fibrosis that's often diagnosed in liver biopsy, or in like adult populations, they actually have better non-invasive imaging they can use to define this. Typically, seen in adult patients, MASH can progress to cirrhosis, which is a higher risk for hepatocellular carcinoma developing and is actually the leading cause of liver transplants in adults. For females, it's typically just isolated MASH, but in adults, or males, it's MET ALD, which is the MASLD plus they drink too much alcohol. Accurate diagnosis and staging of MASLD are crucial for effective management of this increasingly prevalent condition, as the severity of disease can inform treatment decisions and guide frequency of monitoring and eventual transition to adult care. As you can see here, the pediatric criteria for the cardiometabolic risk factors are slightly different with some of the ages, percentile cutoffs, and thresholds compared to adults. On liver biopsy, the actual pattern and appearance of MASH in kids looks different compared to adults. Pediatric MASH has more inflammation and fibrosis surrounding the periportal area, which is that area of the portal vein, hepatic artery, and bile ducts, compared to more centrilobular area, which is mostly the central hepatic vein and lobular in between those two veins in adults. So this difference, there's actually data that supports that pediatric MASLD or MASH is more aggressive compared to adults because kids are presenting at a younger age with higher cardiometabolic risk factors, even though adults have similar metabolic profiles. Here's an example of some liver biopsies that I took from the ASLD. Figure A shows the pediatric pattern of steatotic liver disease with the pan-acinar steatosis and the portal inflammation. For those who don't look at pathology regularly, the white circles are areas of fat, and the bright purple, more coloring, is actually the inflammation. So you can see where I put the arrows. In figure A, that's the portal area in a pediatric child with predominant inflammation, and figure B is an example of an adult who has steatosis, along with inflammation primarily in the centrozonal area. Figure C is just a pediatric patient that has steatosis, but is not quite as severe as figure A. In a larger study, looking more at the prevalence now of Maselden MASH, using the teen labs data, they had found that about 2/3 of adolescents undergoing bariatric surgery had Maseled on their liver biopsy, and this was obtained intraoperatively. About 10% of those patients actually had definite MASH. You can see this in figure A. The overall presence of fibrosis, which is that more scarring that advances with chronic inflammation in the liver, is seen in figure B, and the presence overall was mild. In another cohort published in 2016 of kids undergoing Roux-en-Y and sleeve gastrectomies, they found about 1/3 of their patients actually had MASH. I don't have a figure for that one. So this is sort of an outline of the review paper that we published last year, reviewing multiple pediatric studies looking at the outcomes of metabolic and bariatric. However, we know that these studies didn't really follow longitudinally past 12 months, so imagine if their liver enzymes had normalized, their fibrosis was probably improved if they're followed past that. The serum markers, in summary, primarily we just looked at liver enzymes because there wasn't enough data in all these cohort studies of looking at GGTs and other serum markers, but overall showed a decrease over time, with the greatest improvement in those lab values in those who actually had higher baseline liver enzymes or a higher degree of baseline fibrosis. This improvement was sustained up to 2 years after surgery for as long as some of the studies had followed them. Enzymes were normalized in patients with their biopsy. For imaging, there's actually limited pediatric studies available with a reliable imaging modality, so specifically looking at like MRI or CT that can quantify the fat, given the limitations of ultrasound and FibroScan. And so what they did find in 2 studies, one using CT and another with MRI, the CT study found that there was a significant association between changes in the liver enzymes and hepatic fat content after 1 year, suggesting that liver enzymes improvement may not always correlate with the imaging. So the liver enzymes may go down, but the content may not always change. Okay, and then importantly, sort of just comparing these outcomes similarly in adults undergoing MBS, a large meta-analysis that included 37 studies in adults after bariatric surgery showed that liver biopsy confirmed improvements in steatosis along with those findings of ballooning, inflammation, and fibrosis. And recently, actually, I was at DDW this weekend, and they are reporting similar findings with the GLP-1s, and they've actually seen complete improvement in some of the evidence of cirrhosis in some patients too. And increased mortality rate in those with cirrhosis. So specifically, that increased mortality rate was about 1.3% in the patients with cirrhosis. However, when you actually separated it into those with decompensated cirrhosis, meaning probably heading towards transplant, that rate of mortality was 18% compared to 0.9 in those with compensated cirrhosis. So in summary, there's limited longitudinal studies looking at the outcomes of Maseled MASH in adolescents undergoing MBS. MBS may benefit adolescents with severe obesity and MASH, particularly in those with significant fibrosis, which is defined as greater than stage 2. Pediatric studies have observed reduction in liver enzymes, improvement in hepatocyte steatosis, fibrosis, and fat content overall. However, there's not enough longitudinal studies to completely say that it resolves all liver fibrosis. And the lack of resolution of fibrosis in some liver enzymes in children actually supports the data that pediatric MASH is typically more aggressive compared to adults. Additionally, the safety of MBS in children with MASH-related cirrhosis is not established. However, adult studies have observed an increased risk for surgical complications and mortality in those with cirrhosis. So this, again, supports the need for multidisciplinary teams to guide the process through. evaluation of patients who may be undergoing MBS and those who there might actually be concern for liver involvement of their disease, of their chronic illness, especially if there's concern for cirrhosis, and having a better evaluation for portal hypertension. Okay, these are all my references. Okay, I've been told that I keep going, right? Okay, all right. So the next talk, this is looking at the nutritional risks after MBS. So I'm sure everyone in this room knows this, but why micronutrient deficiencies are important in relation to MBS. Obviously, patients with obesity are at risk for micronutrient deficiencies before MBS, and this risk only increases postoperatively. Adverse effects like anemia, osteoporosis, neurologic deficits can develop postoperatively if appropriate oral nutrition and supplementation are not met. And then the previous 5-year outcome data from the teen labs showed that adolescents who underwent Roux-en-Y compared to sleeve gastrectomy had higher rates of deficiencies, especially for iron and vitamin B12. And then low ferritin was actually observed in 71% of those patients who underwent Roux-en-Y compared to the sleeve, who had 45%. And then now with obviously, and hopefully, more anticipated rise in the use of bariatric surgery in pediatrics, long-term outcomes for youth undergoing bariatric surgery need to be better understood. So the objective for this talk, just reviewing the outcomes that we had of the multiple micronutrients in adolescents looking at 10 years after bariatric surgery, looking at things like the vitamin status, iron, calcium homeostasis, and anemia. We used data from the teen labs cohort, which included adolescents 19 and under, who underwent longitudinal assessment for micronutrients pre-op, 6-month post-op, annually for 5 years, and then periodically thereafter. Multivitamin, iron, calcium, vitamin D, B12 supplements were recommended at each follow-up, following the standard of care guidelines, and then participants reported their intake of these supplements. So of the 274 individuals in the cohort, 260 were included in this analysis, and generalized mixed models were used to calculate for the risk of developing micronutrient deficiencies. So by 10 years post-surgery, the BMI was not different between individuals who underwent the Roux-en-Y and the sleeve. By 10 years, regardless of the surgical procedure, over half the patients had remission in type 2 diabetes, hypertension, and dyslipidemia. And then these next 2 slides will review the incidence of the micronutrient deficiencies at 10 years. So here you can see the increased incidence for iron deficiency with high transferrin and low ferritin in 40% of the patients. There's also a persistent measure for decreased bone health with a high PTH and low vitamin D in almost half of the patients in both the sleeve and Roux-en-Y groups. Similarly, looking at the other vitamins, B12 was not able to be modeled, but for folate, there was increased incidence of low folate levels to 9% for those who underwent a sleeve compared to an improvement and a decreased incidence of 4% for those who underwent the Roux. And then interestingly, for both surgical groups, the incidence of low vitamin A actually improved from their baseline. However, there was still a greater increased incidence for those who underwent the Roux-en-Y. So this image just visualizes the overall lower risk of vitamin A deficiency for those who receive a sleeve gastrectomy compared to the Roux-en-Y, and in general, the risk ratios were lower for micronutrient deficiency outcomes for those who underwent a sleeve gastrectomy. Here is the prevalence of anemia measured by hemoglobin levels, which was significantly lower at 10 years after a sleeve gastrectomy. However, the overall prevalence in both groups was still quite high, which is just important to note that about 1 in 4 of the patients who had a sleeve gastrectomy and about 2 out of every 3 for the Roux-en-Y still had anemia 10 years after a bariatric surgery. And then this graph shows the prevalence of micronutrient deficiencies at baseline, 5 and 10 years. By 10 years, half of the participants had evidence of 2 or more micronutrient deficiencies, which was a 5-fold increased prevalence from baseline. Visually, that change is just with an increase of the orange and red over time. And then again, compared to baseline, you can see the increase in multiple deficiencies from about 10 to 50% after both Roux-en-Y and sleeve gastrectomy. I just think it's notable to point out that the deficiencies in the sleeve gastrectomy group did seem to catch up with the Roux-en-Y group by 10 years. Which, sorry, I should have said that's the blue line compared to the red line. So in conclusion, 10 years after MBS, micronutrient deficiencies were common for both the Roux-en-Y and sleeve gastrectomy groups. there are still persistent rates of anemia in both surgical groups, and the markers for decreased bone health still persist at 10 years. Overall, the sleeve gastrectomy participants had a lower prevalence of 2 or more deficiencies, supporting a continued favor for that surgical procedure. And then given just this trend over time of multiple deficiencies, long-term monitoring is still needed to prevent complications. Just want to thank everyone who was involved in this research and who helped with our paper. And pass off to John.
Thank you, Dr. Bricht. I will open it up for questions.
Yeah, so thank you, Christine, for being part of our lab over the last few years, and you've really done great work. I wanted to just answer that question that arose earlier today and get your reflections on it as well, that the Teen Lab's folate measure is a red blood cell folate measure, and so my guess is that there can be more day-to-day fluctuations in the serum measure, because I do remember your work here that is showing it a much more modest number of prevalence for folate deficiency.
Yeah. I think that, is that the question, just that confirming that it does?
Yeah. And then secondly, the liver work is, I think, the part of the least explored in adolescent bariatric outcomes. And it's in part because it is, to do it really well, invasive, for histology at least. But there are other measures, including the
elastography.
Can you talk a little bit about the more non-invasive measures that we might want to look at when we're thinking about future research and outcomes of liver disease?
Yeah, so I know depending on the clinic and hospital settings and ours, we've been talking more about doing this. Like FibroScan is something that can be done sort of at bedside that we do, gives you the CAP measurement, which is sort of an estimate of like fat in the liver, and then the elastography, which is a measure of the liver stiffness. That can be done by us, like we're trying to do that. And then there's just elastography with ultrasound, which our radiography techs will do. Those are things that we use that are non-invasive for patients, and neither of them technically quantify the fat as well as like a MRI or a CT would, and they can be influenced significantly by body habitus. So being obese would change that, and then whether or not the patient is fasting affects the levels as well, and so it's not the most reliable. And then it's just important to note when we're interpreting these, because we do use them, that these machines that we're using were designed for adults, and so they don't necessarily have the same correlation, aren't like designed for kids. And so that is just one difference. But we do use them in our clinic. We will monitor FibroScans in kids just to see if the number is changing. And then I literally just came from clinic where I was ordering an elastography for a child with steatosis. So we do use it. It's just they're not the most, I wouldn't say like the gold standard yet. But I know a lot of research is being done in that for kids.
I just had a quick question about transplantation in pediatric patients that are suffering with obesity. Mm-hmm. Is that usually, I know each center kind of decides if it's a BMI of 30, if it's a BMI of 35. What is it typically in the United States right now? Yeah. And also the second question to that would be, how does obesity affect the life of the transplanted organ? And do we have that information?
So I can't speak specifically that we have had a lot of that in our center. I can only speak to liver transplant. I don't know about like other solid organs, but I know for liver we have patients who are overweight or obese that have needed transplants for other reasons, not because they have cirrhosis or anything related to steatosis. We actually have a patient right now who is 19 or 20 that is definitely obese, and we have been trying to get him on a GLP-1 for sleep apnea, but doesn't qualify for many different insurance reasons. And so that's just something we know going into transplant, but it's been brought up and our surgeons haven't said it's a reason not to transplant them. I don't know if Northwestern, like on the adult side, I imagine they have a cutoff. Usually they're transplanting patients with HCC who are already starting to lose weight because they're sick from related to their steatosis and like complications. So I have not seen us discuss having a cutoff for it because the patients, we have several who are listed for transplant who are definitely obese and we're still transplanting them. So our surgeons haven't brought it up. I'm sure there's something on the adult side they use, but I'm not familiar with it. I can answer that a little bit. Oh yeah.
So
we do a lot of transplants here, and I would say that depending on what organ is being transplanted, depends on what BMI they're using. So I feel like the nephrologist, like kidney transplant, they're generally, their cutoff that they're using or that they state to patients and families and says the obesity medicine providers is like 35, whereas I feel like the cardiac or the heart transplant surgeons are a little bit, they have a little more leeway and they tend to quote 40. Again, you know, it's interesting because now with the cardiac indication for the GLP-1s, actually we can get them covered for some of the patients that need a heart transplant because many of them have already had a cardiovascular event. But the kidney transplant patients, generally we cannot get them covered for. You know, and then the nephrologists tend to say that, you know, often pre-transplant, as their kidney is failing, they often don't have a whole lot of an appetite, and often they, as their kidney function gets worse, their weight actually tends to come down often just because of that. Whereas post-transplant, they're more at risk because they're on like steroids, right? So, whereas a lot of the cardiac transplant patients, they don't put them on steroids for very long, so they don't have that sort of risk factor after. But it is like, it's complicated, yeah.
It's good to know. I didn't actually know that kidney and heart had their own cutoffs for that. I will add too, just from like a liver perspective, that's just interesting from a steatosis, but living donors, like adults who want to be living donors for kids, or we have some patients who will domino their livers, they actually do undergo an evaluation for MASH and steatosis with measurements to make sure that they're safe, because the adult protocols that they do, like on the adult side for donors, is they want to make sure they're not transplanting an organ that has, I think these 10% is like their cutoff for the fat content. So that is just something that affects transplant for kids. All right, pass it to John.
All right, so I have two talks. They're around 6 to 7 minutes, and I know I'm between you and the networking event, so I'm going to go as quick as possible, but also be as clear as I can. And you've already heard enough from me today anyway, so. Okay, so my first talk is going to be on a project that we did on the cost effectiveness of metabolic and bariatric surgery over a 10-year time period. So all of this you know, but in case people watch this in isolation, we know that the CDC estimates that 1 in 5 children are affected by obesity in the United States. We also know that the annual medical cost is $1.3 billion in this population. And we also know through the talks today that first-line treatments of obesity, which includes intensive health behavior and lifestyle modification, as well as medication management, particularly in adolescents with severe obesity, is not completely effective in every patient. Among those patients that have suboptimal response to those first-line treatments, we know that metabolic and bariatric surgery has been associated with substantial long-term weight loss and improvement in obesity-related comorbidities in adolescents with severe obesity. Again, we've seen this today. We've talked about the 10-year Teen Labs outcomes, an average BMI decrease of 20% over 10 years, and remission of obesity-related comorbidities of around 55%. But despite these promising clinical outcomes, there's very limited data to know if the long-term benefits are worth the economic costs of bariatric surgery in adolescents. And so the aim of our study was to evaluate the 10-year cost effectiveness of bariatric surgery compared to non-surgical management of severe obesity in adolescents. So I'm going to try to make this as digestible as possible because cost-effective models can get a little bit nuanced, but we employed a patient-level health state transition model over a 10-year time period with a 1-month cycle length. That's a lot of different words that I'll explain in the next slide. But all participants in this model started at an age of 17 with a BMI of 52, and 75% were female. And we looked at changes in health states following one of 3 interventions: gastric bypass, sleeve gastrectomy, or no surgery. And so this is a simplified schematic of the model, but essentially what we did is we used a computer-based simulated trial to determine the cost effectiveness of hypothetical patients. So you start with a base case adolescent patient with obesity with or without diabetes based on prevalence data that's derived from our clinical sources. Then the patient either does not undergo surgery, undergoes gastric bypass, or undergoes sleeve gastrectomy. The patient then experiences health state transitions, which includes changes in BMI, occurrence of surgical complications, diabetes remission, or micronutrient deficiencies, also according to the probabilities from our clinical data sources. So you have 100,000 hypothetical adolescents that are simulated in each pathway, so a total of 300,000 simulations with cost updates that occur every month over a 10-year period as their health state transitions. And so the two data sources that we use from the surgical cohort, we know about the teen lab study, prospective multi-center observational cohort study, adolescents who underwent bariatric surgery who had follow-up data up to 10 years postoperatively. And then for the non-surgical cohort, we used Cincinnati Children's Hospital's pediatric weight management program. It was a prospective single-center observational cohort study of adolescents who received nutritional counseling and then also participated in group exercise sessions as well as received behavioral intervention therapy. They had participant data available up to year 7.3. So the cost variables that we used are relatively simple. So every participant accrued an annual total direct healthcare cost based on their age, their sex, their diabetes status, and their BMI. And then surgical participants accrued additional costs from the direct costs associated with surgery, early and late postoperative complications, and then long-term monitoring and management of micronutrient deficiencies. And then we adjusted all costs to 2022 US dollars. So the primary outcome variables for the study were threefold. First, total costs. Second was quality adjusted life years, which is a cost effectiveness term that essentially means it's a period of time multiplied by a quality of life value. And that was according to the patient's BMI, surgical complications, and diabetes status as applicable as to whether or not they had diabetes or underwent surgery. And then third, and this is really the most important thing, is we looked at incremental cost effectiveness ratios, or ICERs, which is essentially, in very basic terms, if you're getting enough bang for your buck. So the buck is the incremental cost associated with one intervention over the other. So that's the delta cost. And then the bang is the additional quality of life that you gain between the two interventions. So that's the delta quali. And then we use a cost effectiveness determination of $100,000, which is most commonly used in US cost effectiveness models. So in terms of our results, no surgery was the least costly, right? $41,000 over a 10-year period. That was compared to sleeve gastrectomy, which is just about $72,000. And then Roux-en-Y gastric bypass was just under $80,000. And then in terms of qualities, no surgery provided the least amount of qualities at 6.1, and then sleeve and gastric bypass were essentially the same at 6.9-ish. And then, it looks like I don't know who was responsible for uploading the slides, but no, I'm just kidding. So I'm going to tell you essentially what the results of this were. But so in terms of ICERs, when you compare all three of these interventions together, the ICER for sleeve gastrectomy compared to no surgery was about $45,000, right? And at a willingness to pay threshold of $100,000, that's well below that, right? So we already know in those three interventions that sleeve gastrectomy is cost effective. Okay, so the ICER for sleeve gastrectomy compared to no surgery in a situation where sleeve gastrectomy is on the table was over $500,000. And so that's clearly not cost effective at the $100,000 willingness to pay threshold. Now, let's think about an instance where you don't have gastric bypass on the table. So an instance where that might be contraindicated in a patient who has severe GERD or is not a good candidate for other reasons. In that situation where you're just comparing no surgery to gastric bypass directly, then the ICER for gastric bypass actually decreased to $50,000. So ultimately what you're looking at is both interventions are cost effective. Sleeve is the most when you have all three on the table, but nonetheless, if a patient was not a good candidate for gastric bypass, then for sleeve gastrectomy, then gastric bypass would still be cost effective. So in terms of limitations, I think the most important things are, this is a model that, one of the strengths actually I should say, is that it used prospective 10-year data. A lot of cost-effective models will use 3-year data, 1-year data, and extrapolate over a long period of time. So that's one aspect. I would say limitations, particularly for surgical complications and diabetes remission, we're still looking at in adolescents, so some of that data was derived from adult sources. But ultimately, this is what we found. So I think the main takeaway from this is, when it comes to the future of bariatric surgery, right? If you think about the three-legged stool per se, right? We have the clinical evidence that shows that it's safe. We have the clinical evidence that shows that it's efficacious. You put those things together, which I always say, like, do people agree? Which means, what do the guidelines say? And the answer is we have those things. And then this project in particular, we wanted to answer the third, I think, most important question is it cost effective for us to be doing these surgeries in adolescents with severe obesity? And the answer to that is yes. Ultimately, sleeve gastrectomy being the most cost effective, but again, don't count gastric bypass out, especially in a situation where a patient's not a good candidate for sleeve gastrectomy. So that's my first talk. We're going to move on to the second one. Yes. Yeah, right. Okay, so this next one is a project that I did within the Cchmc data set, looking at age-based disparities in evaluation and utilization of metabolic and bariatric surgery, a real-world cohort study. So again, just to reiterate, the clinical evidence behind long-term efficacy of bariatric surgery in both adolescents and adults is very clear at this point, right? On the adolescent side, we know that data from teen labs showed an average BMI reduction of 20% over 10 years and a remission rate of comorbidities of around 55%. And then the evidence in adults is even more robust. We heard about the Swedish obese subject study today, labs, the Utah obesity study. All of those studies show that bariatric surgery was associated with BMI reductions of 18 to 20% over 10 to 20 years. And those are just a few examples. Data in adults has been accumulating since the 1960s. In light of this evidence, major society guidelines have increasingly endorsed bariatric surgery referral across age groups. So in the pediatric population in 2018, the American Society for Metabolic and Bariatric Surgery began recommending bariatric surgery referral for adolescents aged 10 to 19 years with class 2 obesity plus an obesity-related comorbidity, or class 3 obesity or above, regardless of comorbidity status. And that was renewed again in 2022. And then in 2023, the American Academy of Pediatrics endorsed the same, albeit at a slightly higher minimum age of 13 years, as we know. And then in adults, in 2019, the joint guidelines, so that included the ASMBS, the American College of Endocrinology, the American Society of Anesthesiologists, and others, basically mirror the pediatric ASMBS guidelines. And then in 2022, the American Academy of Family Physicians went even further and included adults with class 1 obesity with uncontrolled diabetes. So the evidence is matching, the guidelines are matching the evidence. But what we wanted to look at with that in mind is two questions. So first, how do rates of bariatric surgery evaluation and utilization compare between adolescents and adults with severe obesity? And then which patients are most likely to actually proceed to surgery? So to answer this question, we used we conducted a retrospective analysis using Cchmc, which was a de-identified EHR-based data, which is a EHR-based data set that includes more than 300 million patients, 2,000 hospitals, and 47,000 clinics. So within Cosmos, we identified two parallel cohorts using identical guideline-based eligibility criteria. So you have adolescents aged 12 to less than 20 with class 2 obesity with a comorbidity, or class 3 obesity or above, regardless of comorbidity status. and an identical cohort of adults aged 20 to 65. And then we identified patients that were evaluated by a bariatric surgeon between 2018 and 2022 in the United States, and then those who subsequently underwent bariatric surgery within 2 years following initial consultation. We just had two components to our analysis. So we described trends in evaluation and surgery rates by age group across the study period, and then we identified predictors of undergoing surgery using chi-squared tests and reported unadjusted odd ratios of 95% confidence intervals. So among over 1.2 million adolescents that met eligibility criteria for bariatric surgery referral in the data set, only 1.2% were evaluated by a bariatric surgeon. And of those, 15.9% underwent surgery within 2 years of initial consultation. Just in adults, just under 34.5 million met eligibility referral criteria, of whom 2.7% were evaluated, and then 27.8% of that subset ultimately proceeded to surgery. And so adults were approximately 2.2-fold higher to undergo, more likely to undergo evaluation, and then 2-fold higher to then subsequently proceed to surgery. And then overall, surgery rates in both groups are extremely low. So 0.2% of the eligible adolescent population and 0.75% of the eligible adult population actually underwent bariatric surgery. But that's just the cumulative numbers from 2018 to 2022. I think it's important to also look at the trends. And so this graph shows the annual consultation rates among 1,000 adults and adolescents meeting criteria for bariatric surgery referral, and then the annual surgery rates among those that were seen by a bariatric surgeon. And so if you look at adult consult rates from 2018 to 2022, they rose 31%, and then surgery rates were essentially unchanged at about an increase of 2.7%. And then adolescent consult rates increased just under 10%, and then surgery rates increased by about 14%. So then if you look at the predictors of undergoing surgery, starting with adults, so adults over the age of 50 had 24% lower odds of proceeding to surgery. Male sex conferred 28% lower odds compared to females. And then for insurance, Medicare patients had 30% lower odds, and uninsured patients had 33% lower odds compared to those with commercial coverage. And then on the comorbidity side, all conditions we examined were associated with higher odds of undergoing surgery. The highest two were obstructive sleep apnea and polycystic ovary syndrome, that they conferred about 2-fold higher odds in the presence of either condition. In adolescents, the pattern was similar, but there were some notable differences. So younger adolescents, those between the ages of 14 and 17, had about 40 to 66% lower odds of undergoing surgery compared to those 18 and 19. Male sex also conferred 32% lower odds compared to females. Rural residence was associated with 29% lower odds compared to urban residents. And then as we saw in adults, comorbidity burden was very strongly associated with higher odds of undergoing surgery, with sleep apnea and PCOS again being the strongest predictors at 2.5 and then 2-fold higher odds, respectively. We also examined whether certain predictors of undergoing surgery differentially affected adolescents versus adults who were evaluated by a bariatric surgeon. And two interactions really stood out. So Black or African American adults had 15% relatively higher odds of undergoing surgery than their adolescent counterparts. And Medicaid coverage was 67%, Medicaid coverage was 67% more strongly associated with undergoing surgery in adults compared to adolescents. So adults with government-funded insurance essentially had higher odds of undergoing surgery. So several important limitations for this study. So first, it's an EHR-based data set, so it's subject to coding errors, incomplete documentation, inconsistency in data capture across centers. It's also limited to centers that use Epic, which tend to be larger medical centers. Second, this is a completely unadjusted set of analyses, so we can't really account for confounding between predictors. And then third, I think, and most importantly, is we assumed equipoise in surgical candidacy between the age groups, and we didn't capture any we didn't capture certain factors that might affect this, like patient or family preferences or psychological readiness, for instance. And so in conclusion, from 2018 to 2022, adults with severe obesity are more than twice as likely to undergo bariatric surgery evaluation and proceed to surgery compared to adolescents, demonstrating that substantial age-based disparities in bariatric surgery access exist. And ultimately, these findings suggest that improving bariatric surgery utilization across age groups represents a critical target for reducing the long-term burden of severe obesity. Thank you.
So, John, I have a question for you, and it may be not possible to answer just based on the granularity of a large data set, but also just curious to hear your thoughts. How many in the adolescent population do you think receive their referral for a pediatric bariatric surgeon versus an adult bariatric surgeon?
Yeah,
and would that potentially impact their ability to get the surgery done?
Yeah, I think that's a good question. So I think Dr. Helmroth brought this up that I think is a really good point, is, you look back at Teen Labs and Amos and, some of the studies that were started 15 years ago, and EPIC just does not provide that same level of granularity. And I could talk about Cosmos for a very long time, which I will not bore everyone with, but depending on what access you have to the data set grants you a little bit more granularity. But I think even with line level data access, it would be very challenging to determine whether or not that encounter that was billed as a bariatric department was provided by a pediatric versus adult surgeon. But it would be very helpful to know, obviously, to help kind of address that access gap, or I should say characterize that a little bit better.
Thank you for both of those study presentations. I think they're both very interesting. For your cost effectiveness study, I'd be curious to see in the era of all these GLP-1s what that data looks like comparatively between the two groups. I think it'll highlight the cost effectiveness of surgery, would be my hypothesis. And then I think it'd also be interesting to see if doing surgery earlier is also more cost effective, so even breaking down the age groups further. But great work.
Yeah, I'll respond to that very briefly by just saying that, again, I think one of the strengths of the modeling that my colleague at Columbia did, Francesca Lim, she's phenomenal, is that all of that data was prospective through 10 years, versus with the GLP-1s, all of that trial data is to like the 1 to 3 year time period. And so we did contemplate including that as a comparator, but you really can't get very reliable outcomes data from that, just because you're postulating everything beyond 1 to 3 years, whereas we have real world data in the surgical and non-surgical folks. But I think that's, as a future direction, something that's really important. Yeah.
Hey, John, great talks. I'm very interested in the cost effectiveness data that you presented. I think that's a really important study. I had two questions. So the first was about your choice of input variables for the model. It seemed pretty restricted relative to what I think is available in Teen Labs. So I was wondering if you could comment on that. And then I was wondering if you could just share some insights into what you think moved the needle the most between the ICER, or the ICER for bypass when sleeve was available versus not, because I thought that was very interesting.
Yeah. Man, I'm so sorry to have to go through these again. But so I'll answer the second question first. So a lot of that has to just do with the fact that if you look at how ICER is calculated, okay, so Roux-en-Y gastric bypass, first of all, the upfront cost is higher. Not very much, right? 80,000 versus 72,000. So that's not a huge difference. The second thing is the complication rate, ever so slightly higher. So those aren't huge. The main driver of that is the quality difference, right? So the denominator here, when you're looking at the difference between 6.875 and 6.888, is really not different. And with similar BMI reductions at 10 years as we saw in Teen Labs, that really drives the difference, right? So that numerator, the difference in the upfront costs and the surgical complications, is really what's driving that, because of the equivalent, essentially, BMI outcomes. And then I'm so sorry, the first question. Input variables, right, yes. So That was on purpose, essentially looking over a 10-year time horizon, what is going to be the most impactful in terms of costs for patients. And what that tends to be is the labs and supplements that you have to take. And then also, if you do have diabetes in particular, all of the medications, monitoring, and comorbidities that would affect your quality of life from that. So we essentially took, to your point, there's a myriad of variables from Teen Labs that we could use. What we thought was going to be the most impactful in terms of cost and quality of life as it relates to comorbidities with severe obesity. All right. Thanks.
All right. Well, this has been phenomenal. I mean, I remember back to 2004 when we sat down, several of us in this room, to write the first guidelines paper and position paper, and we've come a long way. I think that this crowd and the age span, kind of the career stage span here, is exactly what is magical about this kind of a symposium. And it's in part magical because we need that spectrum here. We need the spectrum of expertise, and we need the younger folks that are coming along that are going to really drive this field forward for the next number of decades. We also need the spectrum of the multidisciplinary approaches and thinking that go into this. And I think that you've seen in this lineup every phenotype that is important in these conversations about how do we take care of these patients, how do we do better tomorrow than what we did today. And I have a great deal of enthusiasm for what will be continuing to happen in this field to drive it forward. I'm really excited about, unlike maybe many adult bariatric surgeons these days, I'm really excited about the meds, the advances there, and the advances, quite honestly, in all the treatment modalities, medications, and that we have to look at. So with that, I will adjourn this meeting and be probably reaching out to some of you for input on maybe something else next year. Also wanted to remind you that the CME is available, and we would be happy for you to take advantage of that. Remind you also of visiting the sponsors in the exhibit hall, as they say, and having a drink before heading out tonight. So thanks again, everyone.